of it is being shared. Okay, right, let's go. So welcome to the third in this series of our anti-stigma sessions. In this session, we're going to be sharing our approach to good anti-stigma practice in mental health services. My name's Rachel Gray, I'm a project officer at CME. I'm joined by my colleagues, Anna De Silva and Sarah Harbison, who will be supporting with tech and monitoring in the chart. So as I said, the first half of this session will be presentation-led. What we want to do is share evidence and key findings on what constitutes good anti-stigma practice for reducing mental health stigma within, quite specifically, mental health services. So this is developing work, and we're at the point of looking at what are the fundamental principles needed to really start to embed or to action good anti-stigma practice in mental health services. The second half will be an opportunity for you to ask questions about the evidence base and the implications of the principles that we discuss, with a focus on practice and system level change. So let's go. So we just want to flag up our Safer Space agreement and a content warning. So due to the content of the workshop being around mental health stigma and discrimination, we want to start off by making this agreement an acknowledgement that we will be talking about stigma and discrimination, and that may include stigmatising language and discriminatory practice across gender, race, sexuality, disability and socio-economic deprivation. So if we could all agree to keep ourselves safe within this session, only share information that's ours to share, please take time out if you need to, and to agree that we will show respect for the fact that everyone here has different views and experiences, and we'll treat each other in the way that we would like to be treated ourselves. And finally, that we agree to respect confidentiality. So anything that is shared that's of a personal nature, we won't discuss that outside. And I'm going to assume that everybody's happy to agree to that. Many thanks. So our language and terminology that we use within this session is part of our intention to create and support safer spaces. So language, as we know, is a key aspect in the perpetuation of mental health stigma, and it has a powerful role in shaping perceptions. When particular groups are described in negative or demeaning ways, it reinforces stereotypes, biases, and social inequalities. So we have adapted our language to mitigate harm and to accommodate inclusion. CME is Scotland's national programme to tackle mental health stigma and discrimination. We're funded by the Scottish Government and we're managed by SAMH and the Mental Health Foundation. We influence change in behaviours, cultures and systems so that people with experiences of mental health problems are respected, valued and empowered to achieve the outcomes that are important to them. So we prioritise the settings where people experience the greatest levels of discrimination and stigma, and these are education, health and social care and within employment. So CME has historically taken what can be called a universal approach to its work. In principle, that means that the programme should reach our entire population in Scotland. However, that's not been the case. So in the last few years, we've been digging into the why of this, and we've been developing alternatives to readdress injustice. And the information that we shared today is underpinned by an intersectional approach. It's outlined and embedded in all of the materials that we'll talk about today. And it was the kind of description of what that is, the definition and some exploratory work around that was sent out prior to the session. So we won't go into a huge amount of detail, but if you do need that clarifying understanding, then please refer back to the content that we sent out for a more comprehensive description. So how does mental health stigma and discrimination impact people? Most people living with a mental health condition consider the stigma associated with it to be worse than the condition themselves. And you can see here some of the impacts that people experience. There are clear links between people's experiences of stigma and discrimination and their resulting expectation or anticipation of stigmatising and judgmental treatment, which in turn leads to their disengagement from services. So this speaks to structural stigma in mental health services, which research suggests results in unmet needs, delayed help seeking and treatment withdrawal. Consequently, it's regarded as a fundamental cause of population inequality, and as such, it's recommended that any effort to reduce stigma, that we should place our attention on the healthcare system. That should be a high priority for us. So I'm going to now describe the intentions behind our developing principles and actions to reduce mental health stigma and discrimination in mental health services. So we have pulled together and collated indicators of good anti-stigma and discrimination practice from a wide research base, which we'll discuss in a moment. In collating this evidence, we've identified 8 good anti-stigma practice principles, and these principles align with Sievwright's 4 intersectional stigma reduction intervention principles. So by bringing these things together, we aim to address structural stigma and discrimination in mental health services as issues of quite specifically access and quality of care. And this supports us to understand that we need a combination of measures that would ensure that wider communities of people obtain the mental health care that they need when they need it, and that they receive clinical care that is safe, effective and respectful. And we'll go on to have a think about how do we define safe, effective and respectful, and who gets to determine what is safe, effective and respectful. So in terms of access to services, we're asking, so these are the questions that we're asking ourselves and asking of the research. So can people obtain the mental health care that they need when they need it? Is mental health stigma and discrimination creating barriers of access to people? And is the service physically, culturally, linguistically and financially reachable by all people, inclusive of marginalised and rural communities? And in terms of the quality of service and care, we're asking, how well is the mental health service delivered and experienced by people? Is mental health stigma and discrimination being experienced, and is it impacting the quality of the service? And again, is the clinical care safe, effective and respectful? So some work we've been doing around that is to ask intersectional communities themselves, what does safety, efficacy and respect in mental health mean to you? So is it physical safety? Is it psychological safety? Is it that the service is anti-racist, anti-homophobic, anti-misogynist? Is it intersectionally safe? Is it culturally safe? So there's a lot of questions that we're digging into there and supporting communities themselves to respond to that. So when we talk about mental health stigma and discrimination, what exactly do we mean? So we define stigma as a social process that involves labelling, stereotyping and exclusion of individuals and groups based on perceived differences that deviate from the dominant social norms across gender, race, sexuality, ethnicity, disability, class and wealth. And we define discrimination as a key part of stigma. It's the inequitable or prejudicial treatment of individuals or groups based on their stigmatised identities. And discrimination can be both intentional or unintentional, in that underlying in the work of our organisations, and we don't understand where it is and where it's located. So we can name discrimination as sexism and misogyny, transphobia, racism, xenophobia, homophobia, ableism, and classism. And we understand that mental health stigma and discrimination is not experienced equally by all people. So we define intersectional stigma as multiple forms that mutually shape the lived experience and opportunities of groups who are marginalised, and that this creates distinct disadvantages. And these aspects cannot be understood in isolation from one another. So how do we get from intersectional mental health stigma to discrimination? And this model describes how labelling and stereotyping people with language that positions them as weak, incompetent, dangerous, and to blame for their ill health leads to them being devalued and dehumanised. It then moves to discrimination against them by making it harder to get equitable access, support, and treatment. The red arrow here shows how labelling perpetuates itself, so it's almost like a self-fulfilling process. And as we see here, stigma and marginalisation intersect across identity, social status, and coping behaviours. So what is the purpose of stigma? Why stigmatise people? So it's argued that stigma is a strategically deployed social process. There are academics that define three functions of health-related stigma. So the first is norm enforcement, keeping people in. The second is domination, keeping people down. And the third is keeping people away. And as such, mental health stigma causes and perpetuates inequality, discrimination, and social isolation. And within this, and when we're addressing structural discrimination, we're talking about injustice that is caused by embedded, unquestioned norms, habits, symbols, and within the assumptions that underlie the rules of our institutions. And then it's the collective consequences of following those rules. So the system produces structural stigma. It produces inequalities in access to and quality of care, and it worsens the health outcomes for many and is a major population health issue. So overall, good practice is, in essence, reducing mental health stigma and discrimination. It's integral to delivering accessible, quality care in mental health services. So where and how to begin to unpick all of this? So this model, which we refer to as the SCIP, which talks to the structural, cultural, institutional, and personal levels at which stigma and discrimination are embedded in our institutions, demonstrates that stigma and discrimination operate at multiple levels, and they involve complex social and systemic processes. So using this framework, we can directly pinpoint where issues of access and quality are being compromised or where they're working well across these different levels. Working with this model allows us to really look at the internal structure, the leadership and the governance, which controls and determines resource allocation, policy, processes and practice. We can look at the internal culture, where beliefs, knowledge, practice, behaviour and resource allocation determine people's access to services and the quality of service that they receive. We can pinpoint and look directly at the institutional system, where the service is implemented and delivered by the workforce, and which is determined by the resources that have been allocated from leadership and governance. And then at the personal level, we can look at how access and quality to the service and of the service is experienced by people, patients, service users and carers. So our adapted SCIP framework allows us to strategically identify the how, why and where groups at the greatest risk of experiencing mental health stigma and discrimination are. And it allows us to move to strategic, measurable action for behaviour, system and culture change. So, how do we begin to identify and attend to the how, why and where groups experience these risks? And how do we assert strategic action for behaviour, system and culture change to alleviate it? And this has led us to ask, well, what constitutes good practice? What constitutes good anti-stigma practice? And so that's where we go. So we have gathered evidence from a wide range of sources, as I mentioned. So we've been working with intersectional communities to gather their asserted criteria. We've been working with practitioners and people within institutions to gather their evidence. We've been working with the academic evidence, and we've also been working with the government and institutional frameworks and guidance. And then we've pulled those together, and I'll mention what those are in a second. We've pulled all of those together to assert overall themes, many of which are intertwined, but we have 8 principles. And in the wider programme, our ongoing work is to pinpoint actions that come out of those principles, and then to define what are the most appropriate methodologies and methods that are needed to do the actions effectively. And we're also pinpointing measures of the measurements of the action to allow us to support organisations to evaluate change and to evaluate success. So, to assert these principles, we've drawn from a whole range of strategies and action plans put out by the government and by institutions that are kind of leading on this work. We have, as I said, looked at the academic evidence. We've pulled together academic evidence that comes from both public health and from intersectional sociology that attends specifically to prejudice and discrimination. And that's quite a unique package of evidence that really illuminates exactly what we need to know when we're dealing with stigma and discrimination. We've worked directly with intersectional communities, and we've also pulled from our own Scottish mental illness stigma study. And then we've drawn from practitioners, from nurses, nursing students that we've been working with, from the soon-to-be released Mental Health Nursing Stigma report, and also from practitioners at the Beacon, Hope Point and Nook, who are well known as models of good practice. And we've also gone through the Mental Welfare Commission's local visits and summaries of recommendations and pulled out and made thematic the recommendations that they've made in terms of mental health services. And so we land on 8 core good anti-stigma practice principles. And so these are resource allocation, person-centred rights and trauma-informed care, anti-stigma and inclusion, intersectionality and cultural safety, that should say, co-production, peer involvement and empowerment, collaborative leadership and governance, access, equity and service improvement, holistic, non-medical and community-based approaches, and workforce capacity, training and support. And we've aligned these 8 principles with Sievwright's 4 intersectional stigma reduction principles, which advises that our interventions recognise and name how systems of power intersect to affect individual experiences and fuel stigma, that they aim to dismantle systems of power and oppression and mitigate the harms, that we ensure that community leadership and meaningful engagement is embedded in the interventions that we do, and that within that we support collective action, cohesion and resistance to address intersecting axes of inequality. And so I'm actually going to go back because I'm going to leave that up, but we're a bit early because I've sped through all of that, but I'm going to leave that up for you to ponder, and we're going to take a short 5-minute break and come back at 11:30. Is that okay, Sarah?
It's perfect. I'll stop recording for the 5 minutes and I'll pop it back on once we're all back.
Great. I'm going to leave this slide up, so please do go and get a cup of tea and we'll come back in 5 minutes. So see you here at 12:30. Thank you.
Now, thanks for the reminder.
Thank you. Yeah, so now I invite your reflections on what you've heard. It was a whistle-stop tour, so thanks for bearing with me. Please feel free to use the chat or to raise your hand. I've included some guiding questions here that would really support our work at CME as we develop what we're doing to better support mental health services and practitioners to take action. And bearing in mind that this is developing work and we're at the point of really looking at fundamental principles that are needed, and that, you know, all of that evidence base, pulling it all together into these quite idealistic but ultimately necessary measures to make sure that the widest groups of people can be looked at, you know, can access services and can be looked after really well by them. So our questions for you, and we'll open it up in a moment, is where do you see the barriers and the enablers to adopting these principles? And, you know, bearing in mind that we're not at the point of having documented all the action that's necessary yet. So yeah, if you could identify barriers and enablers, and how would we mitigate or mediate pushback between where there's tensions between ideals and current system constraints? How could we as individuals support the development of immediate, mid-term or long-term principles to make this feel more achievable? How do we make this bite size or, you know, accessible for us as practitioners? And then finally, and we don't have to answer all of these, it's just some ideas, how do we as individuals ground people's willingness to take action in their values and the outcomes that these principles kind of aim to meet? So I'm going to stop sharing now, and we can open the chat to see what your thoughts are. So here we go. Okay, so we welcome you to throw out your questions to us.
There's a question from Guy in the chat, which is finance. So I'm presuming this is a barrier, perhaps, knowing that finance does tend to be a bit of a barrier for everybody.
Yeah.
Finance to effectively fund timely availability for resource allocation even. 2 years waiting list for NHS, reliable third sectors with more than 1 year's funding and collaborative working.
Yeah, perfect. And, you know, resource allocation is a huge one, and it comes through all of the evidence bases. And I think that one of the, you know, the talking to staff and making sure that this is a resource allocation and planning comes from staff, service users, carers and supporters and advocates is one of the key issues, you know, key kind of indicators that we need to be there. Okay.
I think it's a wee hand up from Shell.
Oh yeah. Hello.
Oh, Shell, let me just unmute you. If that worked. There we go.
Hi.
Hi
Sorry.
there. Hi.
Hi. Nice to meet everybody.
You too.
So going back to, I actually feel like I was in all three categories that you spoke about at the start.
Yeah.
And I suppose when you see it now, and it's like, right. But I was a carer before I became disabled,
Uh-huh.
and now I am. I'm trapped. Like coming to you things is the one thing I've looked forward to. You know, because you can't get your appointments with mental health nurses.
Yeah.
You can't really get an appointment with a doctor. You know what I mean?
Yeah.
And when you do go from go to see the mental health people at the hospital, again, you're starting to say things you don't know what forget sections or what this, that. I think every doctor's surgery should have two workers, or at least have. So in our doctors, I've kind of put it to them, but I've not heard back. They have a adapt between in their lunch hour and the surgery. It's not getting used. And I think that would be an amazing thing to have somebody in there all the time that it's a cup of tea and a chat. It's not, oh God, I've got to see mental health nurse, I better make sure that I didn't say this, I don't say that. And unless something red flag, you can pull it back, you know, and there should be more opportunities for people than 5 months. And it's not that, you know, like, I think there should be more in the doctors, and, you know, you don't have a waiting time.
Yeah.
And you could be doing Zooms and, you know, podcasts and things like that. There's so much more that could be getting done that I think doesn't get done, but that's just my opinion. But
No, your opinion is important, Shell, and those are, you know, you're an expert in experience in the service, and it's you know, your opinion and opinion of people that are experiencing the service is absolutely necessary and that's valuable. That's how we can determine getting services to actually serve people. So
I
thank
saw
you.
life in two
Uh-huh.
different ways. So going
Yeah.
from working in a nursing home and
Yeah.
caring for people with a lot of different mental health and disabilities, etc., to literally overnight, literally
Yeah.
becoming disabled.
Yeah.
People saying that, yeah, and people doing it. And you're like, it's me, and they'll do it not anymore. Then the whole stigma was horrific.
Yeah.
Down
You've seen
you
it.
know,
Yeah.
yeah,
You've seen it
and
from all angles. Yeah.
it's two different worlds, you know. I got
Yeah.
a bubble gum pink scooter, and then folk did sort of stay there, and it was like, oh, I really like the scooter, and it made it
Yeah.
feel better. But
Yeah,
from
definitely.
both
Probably
sides,
envious of that scooter.
it's
Sounds amazing.
honestly, if you ever see me pink, you'll know it's me. But
Thank you, Shell. We're gonna
look at it.
thanks so much for your input. We're gonna go to Quinn, who has his hand up. Hi there. Oh, can we unmute Quinn?
Is that better? Can you hear me?
Yeah.
Hi, cool. Hi, I'm Quint. I'm a mental health work coach at the job centre. So, I'm kind of almost probably a middleman between people that require the service and them actually having access to it, which is really difficult, as I'm sure you can imagine. I meet lots of different people with lots of different conditions, and when they're waiting for that type of intervention from a mental health service, it's just too long. It just takes too long. I'm obviously limited in what I can do. I can't like take on a patient caseload as such, but I'm lucky in the respect that I do get to work with people for longer periods of time than what a normal work coach would be able to do, not the sort of 10-minute stuff. But I can see people a lot more frequently, and I can I can have like half-hour or even hour appointments if that's necessary.
Mm-hmm.
It's a bit of a band-aid,
Mm.
possibly, you know, but it's I think it's a really important resource. You know, as a midway point for people,
Yeah.
to just try and build a bit of self-esteem, a bit of confidence, um, give them an idea of what the intervention is going to look like for them when they eventually do get that professional help.
Yeah.
This doesn't happen in every job centre. I'm sad to say, but it's something that I've been passionate about for a long time, and
Mm-hmm.
the management structure that we have here has been really good and let me do this. But it is something that hopefully is going to be rolled out over other centres, because this is this is something that I know a lot of people in the service are passionate about, but
Mm.
the training for us is not there. It's, you know, it's stuff that
Yeah.
we have to do ourselves,
Mm-hmm.
through people like yourself. Hence the reason I'm on this today.
Yeah.
Um, but just to kind of assure people like Shell as well that there is help out there.
Mm.
It's not the easiest to find a
No.
lot of the time, and I get that, but ask around, you know,
Mm-hmm.
speak to people, network with people. You know, the more of us that are together, the more of an impact we can have.
Yeah, that's so positive, Gwen. Thank you for doing that work. And I do, you know, it's a real shame that it's not consistent across job centres, and that it's been, you know, a lot of this stuff relies on individuals kind of
Yeah,
seeing what needs to be done and taking ownership of that,
all right.
which is what should be the norm, really, you know, or
Yeah,
it should be planned into the work. And I think that what you raise, and you know, being from the job centre, it also raises the issue of how services are talking to each other, and the need
mhm,
for a disciplinary approach in terms of multiple systems coming
yeah,
together to support people. So, you know, and that came through in the research, that people want to have everything be joined up. So
yeah,
housing, welfare, you know, their mental health
yep,
support, physical health support, all of the different things need to be connected, because each system being separate and different means that it has different access rules, and, you know, and different degrees of quality. And so
yeah,
someone may come and see you and have a really good experience, but go into another service and have a terrible experience. So,
yeah.
and there is no consistency across all of it. So
No,
I
I'm
think
working on it, Rachel. I'm working on
you're not alone, Quinn. I
it.
don't want you to feel alone in this.
No,
We're behind you.
we have got we're in the middle. I'm not going to be very specific here, obviously, for confidentiality purposes,
Yeah,
but we I'm currently working with a guy who's been through, well, absolute hell, and we do
yeah,
need to have multi-agency meetings that haven't been done before.
yeah,
Um, but we are bringing people together, and people
mhm,
are keen to see that meeting go ahead.
yeah,
It's probably not the best time of year with holidays and stuff like that, trying to get
mhm,
people in the right place for the right time. But it is happening. It has been agreed, and it is moving
mm,
forward. And I'm hoping, fingers crossed, that will
mhm.
be a springboard to more of these interventions taking place, and more of that engagement and joined up uh, agency support.
Yeah,
Because yeah, I mean, building that network, and uh,
mhm,
not having people running about here, there, and everywhere trying to get support. If they can
exactly.
come to one place and have that support there, um, or have us reach out to get them that support and
Yeah.
make these multi-agency meetings happen,
Mm-hmm.
I think things could potentially move a lot quicker than they are.
It would be good to stay in touch with you, Quinn, actually, and to follow what you're doing. So I wonder, my email's on the slide at the very end of this, and I'll share that. But if you wouldn't mind dropping me a little email, I'd love to kind of document your practice, because I
Thank
think
you. That would be great.
it sounds like good anti-stigma practice and something that it would be interesting to follow. So thank you for contributing. Thanks.
No problem.
We're
Thank you.
going to go to Shobin next. Hi, Shobin.
Hello, am I audible to everybody? Hi.
Yeah.
Hi, this is my first meeting with the See Me session, so I'm very happy I'm part of this. What I was thinking, maybe I should just tell everybody on the group that what I'm doing. So I'm back in training, so I'm a doctor in mental health, but especially with the cohort of patients who have intellectual disabilities. I see a lot of patients transitioning from child to adults, and a common theme is more than the disability itself, it's the stigma attached to it that troubles most of my patients, which is what got me interested into, like, okay, what can we do as professionals? We are quite blessed to be in a particular position where we can initiate action or help out everybody. So that then brought me back. I'm always someone who works with or believes that we have to start at a very, very low community level, because there are so many who use our services, but because of stigma related issues, many that don't. So always my primary target for a very long time, for any issues that I face in my workplace, is always, let's target the community, what's happening there. But
Exactly.
interestingly, what I understood was, it's in within the community, yes, it's a huge different age cohort, but this, what I believe is, the most efficient target aimed should be at primary school level, because these children are just sponges waiting to absorb any information.
Yeah.
And it can be good, it can be bad. A very simple example was like, my son, he was we were in England till about 2 months back, so there we have the reception, which is equivalent to, before they start their
Nursery.
P1 here. Yeah.
Yeah.
So in his reception class, there was a child with, who was differently abled, and he was a little, slow in reading and writing. And how my little son used to address him, or if there was a rip on one of the story pages, oh, that must be my little so and so, the name of the child who did this. That's okay, it's just because he just doesn't understand. And that's what Miss Phillip told us why it happened. So it was so clean cut, and he didn't have to think beyond it, or why is that child ripping the book, or why is that child exempted from being told off when he's ripped off a book. They just told what it is, and it is what it is, and he didn't see the child differently. And that's what got me thinking, like, wow, that's the perfect target. And that's what got me looking into, and I came upon See Me. I do understand that there's been a pilot program across schools, but it kept me wondering. Yes, the program happened. I've seen excellent reports across different places, but is this ongoing? Are the schools doing this on a continuous basis? Because they need to repeat this for every year that comes. It
Yeah.
might it's so, because unless we don't do that, we are addressing the current generation, yes, but we
Yeah.
need to also target them. So I
Yeah.
think when I saw your slide, I saw that holistic, non-medical, community-based approach. I was like, oh, I'm targeting that. I have to do something about that.
Yeah. I mean, the work that CME's been doing in schools is generally, it has been
Amazing. Yes.
it's embedded and it's been repeated over and over again for quite a while. Actually, I would have to refer to my colleagues for more information about that, for how long. But it is a significant amount of time.
Yeah.
But what I do know is that the content is not intersectional. So whether it really considers learning disability, neurodivergence, or, you know, race, class, those kind of things is something that, you know, needs to be looked at. So I think it, you know, it has traditionally taken the universal approach to mental health stigma, which then doesn't dig into the intersectional experience of mental health stigma and ableism, or you know, other aspects of discrimination. So I know that you're in contact with my colleague Bryony, and that would be great for you to do some stuff together. And
it's my area of interest.
Yeah, fantastic. And we're also in contact. I emailed you the other day.
You did.
So because we're doing work with undergraduate pre-registration healthcare students, so to really get in before people go into services. But then, you know, so the students face their own kind of issues going into, and where they've been trained in kind of anti-racism and intersectional practice. When they get into services, they're also experiencing barriers, and there's issues of hierarchy and embedded issues in services as there is. But we'll keep trying it all to get it from all angles.
I know.
Thank you for your contribution, Siobhan.
Yes, no problem.
Thank you. And so the next person with their hand up, it says CCC admin.
Hiya.
Hi.
Hiya. Thank you. We were quite late in, sorry. We're Ksenia's got a migraine, that's why she's got that on her head.
Oh, you poor thing, it's awful.
We lamb. Your music to my ears as a practitioner with children, young people, homelessness, domestic abuse, community-based for over 30 years. All my notes are all about, you know, somebody needs to join all these policies up, you know, that intersectionality is critical. The risk trajectory, you know, with people who've had adverse childhood experiences.
Exactly.
And I think even in situations where we would expect to see that being really tightly managed, it's not, and it breaks my heart almost weekly to see people who are being spat out of the big machine. When we know their lived experiences, we could almost write it in the stars. And I have a real commitment with lived experience myself and ongoing of we need to change this. You know, we're meant to be trauma-informed Scotland. Where's the progress on that? Who's doing the joining up on it? Where's the, you know, where's the folk coming into our community centre? So I'm preaching to the converted, I know, but I suppose it's, for me, I feel like we've got opportunities with the trauma-informed, the domestic abuse bills, the promise that's going on, the tipping point that's happening in prisons, community policing, victim support, and I want a strong lobbying boxing of ears to get people to listen that, you know, mental health is not in a vacuum, and it's not just poor mental health, it's not just bad days, it's ongoing, it's forever, you know, we have from day dot till the day we die, and it has to be more than medicalised.
Exactly. Well, I'm absolutely with you on that. And, you know, like you're making me think that what we need is some kind of community for ourselves that is, you know, a social movement. You know, that we are all part of that people are that are wanting to join the dots of those different aspects of people's lived experience and bring them all together. So I just saw one of the questions that had been said. So Shell had mentioned young offenders, and you know, and the intersectional approach is the way to do this, to really map out all of the different aspects of people's lives and lived experience to address exactly those things. And then, you know, Quinn's work around these joining up services, you know, we know that poverty is one of the most enduring you know, inequities of our time, along with everything else, but it's particularly insidious at the moment, and we know why and where that's coming from. And unfortunately, people are punching down instead of up when we're thinking about inequality. But yeah, that's also, could you send me a little email, and maybe we could send something out to the whole group saying, if people want to continue this conversation, let's get together around joining everything up, because I think it's worthwhile.
Yeah, I think so. Thank you for letting me rant.
Absolutely, that was a beautiful rant. So we've got one more minute before we kind of start to close up the session. So does anybody have anything else that they would like to say? I can see Monique in the chat has said that there's some great work going on just now, joining up anti-stigma work and substance use. So mental health and substance use. And yeah, I think this aligning thing is exactly what needs to happen. And what we'll end up with is a huge big thing, but we need to know exactly what it is that we're dealing with, rather than it all being siloed out into little pockets of disparate practice, and you know, people just left isolated. So listen, everybody, that's us come to 5 to 12, and I'm just going to share my screen because I want to just show you one last slide. And so it's our conference on the 1st of October. At last count, we had 5 spaces left. So I think Sarah will now put the link in the chat. So if you're very quick and you're of that mind, you can try and get one of those 5 tickets. And what we can promise is that that is going to be a transformative event. We're super excited about it. We've got amazing speakers coming. It'll be about intersectionality and about really shifting the dial on how we approach mental health stigma and discrimination in Scotland. So we would really love to see you there. And in the meantime, my email is on here. Please email me if you'd like to have a chat, and if you would like to have a look at our website, please do that. And I'll stop sharing and just come back to you to say thank you, and good luck with all the amazing work that you're doing. We'll keep going, you keep going, and we'll do another one of these sessions soon. So keep an eye on our social media and stuff. So thank you.